Yoga for our hands. Our modern diet and lifestyle have caused profound changes in the musculoskeletal system. Diabetes, prediabetes, obesity, and deconditioning have made the tendons and nerves more prone to inflammation. There is a process called advanced glycemic end product formation, which is the abnormal absorption of sugar breakdown products into the nerves and tendons. These cells swell and cause many conditions such as fibromyalgia, carpal tunnel syndrome, tennis elbow, and rotator cuff tendonitis. Tenosynovitis of the hands, better known as trigger finger, is a less serious but a very annoying condition, especially when the finger locks into flexion unexpectedly. When that happens, the finger needs to be pulled out into extension with the other hand, like the trigger on a gun, hence the label. A common misconception of trigger finger is that it is caused by arthritis of the joints. The reality is that the tendons are getting caught under pulleys in the flexor sheath. These pulleys are like belt loops on a pair of pants. If the belt is thick or boggy, it will hang up on the loops. There are several tendons in each finger that need to glide smoothly to prevent locking or pain in the hand. There are several pulleys that go over the top of the flexor tendon that keep the tendon from bowstringing. Without these pulleys, the tendon would bowstring and the efficiency would go down in the flexor tendons. The most common pulley that catches the flexor tendon is the A1 pulley, which is right over what we call the MP joint. That's this joint here. There's also an accessory palmar pulley that can also trap these tendons and can be excised. The less common pulley is the A3 pulley, which is here. And many times when I do surgery, I'll release these two pulleys, wake the patient up to make sure that this pulley is not hanging up the tendon. As long as you have a good A2 pulley and an A4 pulley, the tendon won't bowstring and the efficiency is maintained. In addition, the lateral band makes the tendons makes the fingers fully extend at the IP joints and allows the MP joints to flex. So this tendon also has to glide, and many times the extensor tendon can sublux one way or the other, causing the finger to hang up as well, because the lateral bands and the extensor tendons are not balanced. These are much less common than we see on the flexor side. Fortunately, the nerves in the finger are well away from the tendons and are not directly impacted by the tendons, even when there is severe tenosynovitis. However, in the wrist, the flexor tendons and the lumbrical muscles can crowd out the median nerve and cause or contribute to carpal tunnel syndrome with numbness into the fingers. The treatment for tendonitis in general should start with diet. It is very important that diabetes and prediabetes be under tight control. Most people use an A1C measurement to see if their diabetes is under control. This is a good test in general for diabetes. For tendonitis in the upper extremities, I prefer to check a fasting blood sugar in the morning. The blood sugar should be less than 110 milligrams per deciliter and preferably less than 100 milligrams per deciliter. The reason for this is that if the blood sugar is high while one is sleeping and inactive, excess sugars can get into the tendons and cause abnormal breakdown products, as I've discussed. If the blood sugar is low in the morning, then it is less likely that this abnormal glycemic process has occurred during the night. The next most important thing is to be sure that one is exercising the hands. I usually recommend maximum motion with minimum stress to the hand. Activities such as playing the piano and typing are good for the hand and the tendons because they allow the tendons to glide. Whereas activities such as knitting or weeding gardens will cause a lot of stress to the hands and can increase the inflammation. What I've found over the years is that exercise and stretching of the fingers can markedly improve the presentation of tendonitis in the hands. This can be accomplished by a series of exercises which I will outline. The thing is to stretch each finger individually, and you have to hyperextend the finger and hold it to really stretch it out. Just a little bit of stretch is not good. It has to be way back like this to really stretch out each individual tendon. And you got to do each finger. Sometimes you'll actually hear the fingers crack when this happens, and that's, I call it good crack. It means that the tendon is breaking loose from adhesions inside the pulley. Each finger individually. And you can also do the thumb all the way back. You can also massage the A1 pulley area in each finger to make sure that it's gliding nicely underneath the pulleys as the tendons glide back and forth. Sometimes the A3 pulleys here are also tight, and you can massage those as well. Then the next thing is to do what I call a semi-flex position of the finger. So I'm pulling each finger back individually. This way, you show that. This way. And that way. So you have to have each finger all the way back. Each finger is fully straight, but it's being bent at the MP joints and straight at the IP joints. And then, of course, you go back to the fully extended position. So you have 4 basic positions of the hand: the fully extended position, the semi-flexed position, the fully flexed position, and the intrinsic plus position. Once you can do this consistently every day, the fingers will maintain maximum suppleness, and you can avoid many of the ravages of trigger finger. It's important that these exercises are carried out on a regular basis. However, they're easy to do and can be done by warming the hands with moist or dry heat to allow the tendons to stretch easier. In severe cases, ice can be used after the exercises to limit inflammation. A deep massage is also helpful for these cases, but an ultrasound or TENS unit is rarely necessary in most situations. The more severe cases that do not respond to exercise can be treated with cortisone injections. In my opinion, splints of any kind are counterproductive for this condition. For the most severe cases, surgery can be done. In surgery, the constricting bands around the tendons are released to allow better gliding. Usually having one pulley released is enough. This is analogous to cutting a belt loop to allow the belt to glide. Because you have more than one belt loop, the belt stays put. Likewise, the tendon is stable in the finger with the remaining pulleys. To expose the A1 pulley and the palmar pulley at the level of the MP joint in the palm. Once the pulley is exposed, it is fully removed and the tendon underneath is exposed. There are 2 tendons that are pulled out into the wound and held with clamps to remove the synovitis. Once the synovitis is fully removed, the finger is fully flexed and fully extended and even hyperextended to be sure there's no residual catching or bogginess of the tendon. The patient at this point is woken up from sleep to be sure that he can actively flex and extend the finger without any residual catching. In some cases, there's residual catching at the PIP joint, as I've described previously. Finally, the wound is closed with subarticular stitches and allowed to heal quickly. Normally the healing time for these surgeries is less than 2 weeks. Patients are started on immediate motion in the post-operative period. In my experience, most cases do not require surgery and will respond to conservative treatment, including cortisone injections. In conclusion, like dental hygiene, which is necessary to prevent serious problems with the teeth and gums, yoga for your hands can be an easy and effective way to maintain good function of the hands and prevent progressive locking or triggering, which may require surgery. It is very important to be sure that diabetes or prediabetes is under tight control, since this can cause more serious problems, as I've indicated previously.